السلام عليكم. بسم الله الرحمن الرحيم. محاضرتنا اليوم Anatomy of the Hiatus. أنا دكتور محمد توفيق الرويني, Professor of Surgery working at the GIT Surgery Unit, Faculty of Medicine, University of Alexandria. The objectives of this topic is to demonstrate the anatomy of the esophageal hiatus, the relations and structures in and around this hiatus, and the surgical importance of the anatomical composition of this area. This includes the different surgical pathologies around the hiatus of the esophagus and the different types of surgeries that are done around this region. So when we say that this is anatomy of the hiatus, it means that from a surgical point of view, it is the surgical importance or the surgical anatomy of the hiatus. Detailed anatomy of the hiatus can be seen, or we can review it in a textbook of anatomy. The esophagus is a muscular tube of approximately 25 centimeters that extends from the pharynx to the stomach. It has an average diameter of 2 centimeters and it conveys food from the pharynx to the stomach. As seen during fluoroscopy, that means that during a barium swallow, the esophagus normally has 3 constrictions: from the pressure or the outer compression, mild compression, of course, of the structures that are present in its neighborhood. At the level of the cervical region, this compression or this the constriction is at the pharyngoesophageal junction. In the chest, it is around the arch of the aorta, and in the abdomen, it is in the region where the esophagus passes through the hiatus of the diaphragm, approximately 40 centimeters from the incisors teeth, and this is the topic of this lecture. So, this is the esophagus, in front is the trachea, this is the arch of the aorta, and the descending aorta, which passes behind the esophagus, the right vagus nerve, the left vagus nerve. This is the hiatus, which is composed of the right crus and the left crus, which extends to insert in the vertebra, making the arcuate ligament from which passes the aorta. So this is the thoracic compression or the thoracic constriction around the bronchoaortic from the aortic arch, and this is the compression in the diaphragmatic hiatus, which is the abdominal part. The esophagus is formed of different layers which construct the esophageal layers. The tunica adventitia, which is formed of loose connective tissue and separate the esophagus in the chest or in the thorax or in the mediastinum, posterior mediastinum, from the adjacent and neighborhood structures. The esophagus is one of the GIT parts which has not a cirrhosis. The tunica muscularis, it is formed of smooth muscle fibers. We have 2 layers of smooth muscle fibers. We have the outer layer, which is longitudinal, and we have the inner layer, which is circular muscle fibers. And these fibers extend from the pharynx to the insertion or to the entry of the esophagus in the stomach. We speak about 2 sphincters in the esophagus. One is anatomical, one is the upper esophageal sphincter at the cricopharyngeal region, and a lower esophageal sphincter, which there is a lot of dispute about the anatomical presence, the real presence of an anatomical sphincter, or it is simply a high pressure zone, and we will discuss this later. There is submucosa, which is formed of it is a connective tissue layer that contains small blood vessels, lymphatics, nerves, and mucous glands. The tunica mucosa, it is formed of non-keratinizing stratified squamous epithelium. The Z line at the mucosa is an important landmark. It is a serrated, clearly abrupt, demarcated line which shows a transition between the esophageal mucosa, which is stratified squamous epithelium, and the gastric cardiac mucosa. The esophageal mucosa is pale, parchment-like, and the gastric cardiac mucosa is a red color mucosa, and the Z line makes the distinction between the two types of mucosa at the Z line. So this is an important line because it denotes the gastroesophageal junction, and any proximal extension of gastric or intestinal type columnar epithelium, as we will discuss it later, is considered pathologic and could be attributed to gastroesophageal reflux disease. The diaphragm, the hiatus itself. The diaphragm has three major openings: the esophageal hiatus, the opening in the diaphragm for the passage of the inferior vena cava, and the aortic hiatus, which transmit the aorta. The inferior vena cava runs posterior to the liver and through the diaphragm at the right side of the central tendon and at the right side of the abdominal esophagus. Although the inferior vena cava is generally not encountered during routine anti-reflux surgery, it can be very close to the margin of the right crus during esophageal or hiatal repair, whether it is for hiatus hernia, whether it is for gastroesophageal reflux. When the hiatus is wide, we usually take sutures to approximate the right and left crus to make this opening narrower, to prevent reflux and to prevent herniation of the stomach in the chest. And during taking these sutures, if we are not careful, we may transfix the inferior vena cava, which is nearby, but we have to take care. Also, the aorta is posterior to the esophagus at the end or at the decussation of the right and left crus at the arcuate ligament, so we have also to take care from the presence of the posterior esophagus, of the posterior aorta. The diaphragmatic crura, the right and left crus, tethers the diaphragm to the vertebral column. These legs of the diaphragm split from the central tendon and extend around the esophagus to create the hiatus. The area where the legs cross inferiorly to the esophagus and across the aorta is known as the median arcuate ligament or the crural decussation. So this is clear here. This is the diaphragm, this is the central tendon of the diaphragm, this is the hiatus or the opening for the inferior vena cava, this is the right crus, and this is the left crus, and both of them tether and insert in the vertebra, and at the region where they decussate or they meet, they form the median arcuate ligament, and the esophagus passes through the right and left crus to form the hiatal region. What are the structures that pass through the esophageal hiatus? There is the esophagus, the phrenoesophageal ligament, the left and right vagus nerves, the esophageal branches of the left gastric artery and vein, and some lymphatics. The gastroesophageal junction. The normal gastroesophageal junction lies within the abdomen. This means that the esophagus terminates in the abdominal cavity. So it is important to know that there is an abdominal part of the esophagus. Esophagus has cervical part, a thoracic part, and an abdominal part. The abdominal part ranges between 2 and 4 centimeters. This is an important and has an importance in the mechanisms of anti-reflux. The longitudinal and circular muscle fibers extend from the thoracic esophagus across the gastroesophageal junction, where they are joined by the sling fibers that help create the angle of Hiss. This means that the esophagus is formed by longitudinal and circular muscle fibers, and these muscle fibers encounter a third layer which comes at the cardia, which are the sling fibers, which are oblique muscle fibers that are present at the cardiac orifice. The lower esophageal sphincter is made up of prominent circular muscles that form the gastroesophageal junction. So this is the picture. We have here the circular muscles, which we call clasps, and here are the oblique muscle fibers, which we call the sling fibers, and the contraction of the sling fibers make the angle of Hiss more acute. So if the angle of Hiss is at this level, when these fibers contract, it makes this angle more acute, which has an important role as a barrier for reflux. Reflux means that the contents of the stomach may go upward in the esophagus, causing detrimental effect. If this is chronic, repeated, this causes detrimental effect on the esophageal mucosa, which is stratified squamous epithelium, which is not prepared for the acidity and the enzymes and the bile, if it is present, to sustain the detrimentous effect of the acid, the enzymes, and the bile if they go in the esophagus for a long time. So when these fibers contract, they make this angle more acute. This angle is less acute in the relaxed position and more acute in the contracted position. What is the phrenoesophageal ligament? The phrenoesophageal ligament is important. It is an extension of the inferior diaphragmatic fascia, which is continuous with the fascia transversalis of the abdomen and attaches to the esophagus at the gastroesophageal junction. So it has two functions. One, it anchors the esophagus or the gastroesophageal junction or this area of high pressure zone in its position, preventing its migration inside the chest, and it seals the abdominal cavity from the thoracic cavity. So the phrenoesophageal ligament serves to seal the esophageal hiatus, because it's an opening between the mediastinum or the thorax and the abdomen, to maintain separation between the thoracic cavity and the abdominal cavity. The upper layers of the phrenoesophageal ligament extend into the mediastinum and attach to the esophagus and anchors the esophagus to the superior aspect of the diaphragmatic hiatus, while the lower layers secure the bottom of the gastroesophageal junction and to proximal stomach to the inferior surface of the diaphragm. So this is the squamo-columnar junction, this is squamous epithelium, this is columnar epithelium, this is the Z line, serrated line, irregular line between the esophageal mucosa and gastric mucosa. These are the longitudinal muscles, these are the circular muscles, and comes to them the sling fibers of the cardia, which play an important role as we discussed, and this is the diaphragm. This is the crural port left cross, this is the right cross, and this is the phrenoesophageal membrane. The phrenoesophageal ligament or the phrenoesophageal membrane is an extension of the fascia of the abdomen, the posterior fascia of the abdomen, onto the esophagus to anchor it to the diaphragm. So The esophagus is attached to the margins of the esophageal hiatus by the phrenoesophageal ligament, which is an extension of the diaphragmatic fascia, So this is the endo-abdominal fascia. The endo-abdominal fascia splits into an upper leg and a lower leg. The upper leg attaches to the esophagus in the chest, and the other one splits and attaches the esophagus and the stomach to the diaphragm, and as we see, it causes some sort of sealing, separating the thoracic cavity from the abdominal cavity. Which is important to say also that this layer anchors the esophagus, but it's not completely attached to it, as here there is some fat and some connective tissue. This permits for this region to be mechanically mobile region that permits for the esophagus and the lower esophageal sphincter and to this area to move with deglutition and swallowing, and with extension or distension of the stomach, and this permits mobility and some mobility in this region, but also anchors the stomach not to herniate in the chest unless these ligaments become redundant, and at this time this herniation can occur or reflux can occur. This ligament permits independent movement of the diaphragm and esophagus during respiration and swallowing. So this is the endo-abdominal fascia or inferior diaphragmatic fascia that has an endothoracic part and a lower part. This is the phrenoesophageal ligament. The esophagus, its posterior surface of the abdominal part is covered with peritoneum of the oment of the lesser sac, which is continuous with that covering the posterior surface of the stomach. This is the parietal peritoneum, which goes and comes back on the posterior abdominal wall, and the right border of the abdominal esophagus is also continuous with the lesser curvature of the stomach. However, its left border is separated from the fundus of the stomach by the cardiac notch, what we call the angle of His between the esophagus and the fundus. So, again, the surgeons and the endoscopists designate this Z line as a serrated line where the mucosa abruptly changes from esophageal to gastric mucosa, and they call this is the junction or the gastroesophageal junction. Immediately superior to this junction here is the musculature of the right crus of the diaphragm, forming the esophageal hiatus, which function as a corkscrew or as an extrinsic inferior physiological sphincter that contracts and relaxes, usually in concert with a variably thickened muscular coat of the muscles of the cardiac region or the hiatal region. The vagal trunks. Associated with the esophagus as it enters the abdominal cavity are the anterior and posterior vagal trunks. The anterior vagal trunk consists of several smaller trunks whose fibers mostly come from the left vagus nerve, and rotation of the gut during development moves these trunks from the left side to the anterior surface of the esophagus. The posterior vagal trunk consists of a single trunk whose fibers mostly come from the right vagus, and also rotation during development moves this trunk to the posterior surface of the esophagus. This is the right vagus, only one trunk. It is the posterior vagal, forms the posterior vagus, and this left vagus forms the anterior vagus, which has different fibers that lie beneath the phrenoesophageal membrane in direct contact with the esophagus, different from the posterior trunk of the vagus, which is some sort not truly attached to the esophagus and separated from it to a certain level. Okay, this is the right vagus, which gives the posterior vagus, the left vagus, which gives the anterior vagus, and then they will give the hepatic branch and celiac branches after that, as we will see. Physiology of the hiatus. 4 major physiologic mechanisms protect against esophageal acid injury. So as we said, that there is the esophagus comes into the stomach. The stomach is a tube or GIT tube, which is larger than the esophagus. The pressure in the abdomen is higher than the pressure in the chest, so the pressure in the stomach is usually higher than the pressure in the lower thoracic esophagus. So there should be a certain mechanism that prevent from reflux of gastric contents into the lower esophagus or in the thoracic esophagus, because food should pass in one direction and should not come back as a refluxate into the lower esophagus. One of this importance is the lower esophageal sphincter competence. Part of it has been discussed in the anatomy. We have seen that the diaphragmatic crura, the right and the left crus, they surround the esophagus in this region and they exert some pressure and some contractions, making some sort of sphincter. We have discussed the angle of His, which is the acute entry of the esophagus into the stomach. We have spoken about the phrenoesophageal membrane attaching the esophagus and the stomach into the hiatal region to the diaphragm, preventing herniation of the stomach upward. And we have discussed an important part is that there should be, or there is usually, an abdominal part of the esophagus which is under the high pressure of the abdomen, exerting some pressure on this region, making the pressure in the lower abdominal esophagus higher than the esophagus in the chest, and this is part of the high pressure zone in the region of the hiatus. So this is why when we discuss anatomically of the presence of a sphincter, dissection or anatomical dissection has not proved exactly the presence of a sphincter as the upper esophageal sphincter or as the pyloric sphincter or as the anal sphincters. So they have specialized muscles, second layers. This is not truly accepted by all the anatomists, and this is why we prefer to speak about a high pressure zone from the different criteria we have discussed, making the pressure in this region a high pressure zone. Whether a true anatomical sphincter is present or whether there is a contribution of the different factors present in this region making a high pressure zone. One of the important mechanisms in the prevention and that protect against esophageal acid injury is the clearance mechanism. Clearance mechanism means that there is peristaltic activity into the esophagus, and once there is a refluxate or some reflux of food or fluid or gastric contents in the lower esophagus, this makes this propulsate a peristaltic activity that pushes this refluxate back into the stomach. The mucosal integrity, the epithelium of the esophagus is healthy, and there is no intercellular spaces that are close together that don't permit for the acid to and the enzymes to come in the deeper layer of the mucosa, making this inflammation that may lead to fibrosis and strictures and so on. The gastric emptying is an important factor because when the content are present in the stomach, they are emptied and they don't stagnate into the stomach. This helps in preventing increase in the gastric pressure, which will increase the pressure inside the stomach, making reflux probably to occur from the stomach to the esophagus. So gastric emptying is an important factor in preventing gastroesophageal reflux and guards against esophageal acid injury. So this is the anti-reflux system. We have spoken of the criteria that make the high pressure zone. We have the circular fibers, we have the sling fibers, we have the crural of the diaphragm, we have the phrenoesophageal membrane, and we have the intra-abdominal part of the esophagus. So the factors involved in the normal prevention of reflux are anatomical factors: lower esophageal sphincter, intrinsic lower esophageal sphincter pressure, it's innate pressure of the muscles in this region, the total length of the lower esophageal sphincter, part of it is the intra-abdominal part of the esophagus, and the intra-abdominal length of lower esophageal sphincter, and the total length of the high pressure zone. The angle of His, it acts as a flap valve mechanism. When it is acute, it prevents against reflux, but if the stomach distends, this will make this angle obtuse and less acute, permitting as a balloon, the neck of a balloon, when the balloon is insufflated, when we at the start there is a neck, but after when we insufflate, the neck diminishes and the high pressure zone diminishes, and this permits for the refluxate or the reflux of gastric contents. The crural fibers of the diaphragm work as a pinchcock action. The mucosal rosette. The mucosal rosette is not a sphincter, but that it's the arrangement of the mucosal folds of the stomach around the gastroesophageal junction that are prominent, that come near together and forming a sort of a mucosal fold or a mucosal rosette that may help in the prevention of reflux. The esophageal clearance is the antegrade esophageal peristalsis. Once there is reflux, the esophageal, there is a peristaltic wave of esophageal contractions that pushes the refluxate back to the stomach, and the saliva, it has a neutralizing and a lubricating action that guards against the harmful effect of refluxate, and the normal gastric motility and emptying, preventing stagnation of food contents, gastric fluids in the stomach, making the pressure in the stomach higher than in the high pressure zone. Normally, the lower esophageal sphincter exists as a zone of high pressure between the esophagus and stomach. When the high pressure zone is lost, reflux occurs. So this is a manometric picture or figure. You have the transducer tracing identify the lower esophageal sphincter. This is an area of high pressure zone. So look, this is the area of high pressure zone, denoting the presence of the high pressure zone at the site of the hiatus, at the site of the lower esophageal sphincter. So when there is swallowing, when there is belching, when we need to vomit, when we need to belch, there is a lot of air in the stomach. This sphincter relaxes, permitting for the food to pass inside the stomach or for belching to occur. So the high pressure drops only after a swallow or when the fundus is usually distended with gas to belch. The physiology of anti-reflux barriers, three components as we discussed: absolute pressure, overall length of the lower esophageal sphincter, and the intra-abdominal length. We discussed about the balloon effect. So the over length of the high pressure zone shortens as the stomach distends. As a balloon which is not insufflated, it has a long neck. When we insufflate it and it increases in volume, the neck is taken with the rest of the body of the balloon and the neck shortens. The neck is comparable to the high pressure zone. So when the stomach distends, there is increasing pressure in the stomach increase, and the high pressure zone diminishes in size and the pressure inside diminishes, and this will lead to reflux. So the over length of the high pressure zone shortens as the stomach distends. Increasing the pressure necessary to maintain the competence is important. Increase the intra-abdominal pressure, which is usually higher than that present in the chest, needs even distribution over the high pressure zone abdominal of the abdomen length of the esophagus to prevent reflux. So the presence of the intra-abdominal part of the esophagus, which is under the high pressure of the abdominal cavity, plays an important role in increasing the pressure in the high pressure zone, preventing reflux. If the intra-abdominal length of the esophagus is short or becomes short due to herniation of the part of the esophagus in the chest, and there is no more intra-abdominal part of the esophagus, the lower esophageal sphincter pressure can be overcome by small increases in the abdominal cavity pressure or in the intragastric pressure. So, variation of the normal acute angle of His to the abnormal dome-shaped angle in sliding hiatal hernia or in gastroesophageal reflux can facilitate the shortening of the lower esophageal sphincter by gastric distension. If sufficient, the intra-abdominal length is important. If sufficient intra-abdominal length is present, the increase in intra-abdominal pressure will occur around the neck of the balloon and preventing gastroesophageal reflux. The physiology of the anti-reflux, the sphincter is defective if its pressure is less than 6 millimeter mercury, if its over length is less than 2, if the abdominal length is less than 1 centimeter. What are the investigations? This is the overview, a rapid overview of the surgical anatomy of the hiatus, the importance, its physiological role in preventing gastroesophageal reflux and the structures that pass around the hiatus. Detailed anatomy of the esophagus and the hiatal region can be revised and reviewed in textbook of anatomy, but this is the part of the anatomy that we need to know to applied surgery, or what we call the surgical anatomy of this region and its surgical importance. To investigate this region, mostly we have the empiric treatment for gastroesophageal reflux to know if it will give a good symptom relief or not, radiography in the form of barium swallow and barium meal, endoscopy to see the anatomy of the gastroesophageal region, junction, and to see the Z-line, to see if there is esophagitis or there is ulceration, if there is a hiatus hernia, and to examine if there is strictures, to examine the stomach, to examine the pylorus, to see if there is gastric outlet obstruction not permitting for gastric emptying, if there is distension of the stomach, if the stomach is free, and also endoscopy is important to see if there is some of the complications of the gastroesophageal reflux. As we said, ulcerations, erosive esophagitis, and also in the case of achalasia, if there is narrowing of the gastroesophageal junction and difficulty in passage of the scope from the stomach, from the esophagus to the stomach. And another investigation is the manometry to measure the pressure of the lower esophageal sphincter, its length, its presence, if there is peristaltic activity or there is no peristaltic activity, as in the case of achalasia. pH monitoring is important and is one of the most important investigation to prove the presence of gastroesophageal or acidic gastroesophageal reflux. Impedance is a new investigation that measures the resistance to the passage of electrons and electricity from one point of the electrode to another, and this also help in the detection of gastroesophageal reflux. What are the common pathologies at the hiatus? We will mention them, but each item of these pathologies has its own lecture. So you have a lecture about the gastroesophageal reflux, which has been detailed for you. and achalasia, hiatus hernia, gastric malignancies. These are the common pathologies which are present around the hiatus. So, gastroesophageal reflux, it's a condition which develops when the reflux of the stomach contents cause troublesome symptoms and or complications in the lower esophageal mucosa, and this will occur if there is more than 2 heartburn episodes per week or adversely affect an individual's well-being. This means that we have physiological reflux. Every one of us had sustained an episode of reflux once per month, once every 2 months, once per year. This is not a gastroesophageal reflux disease. This is physiological reflux. But we speak about disease when there is affection of the individual's life, when it causes troublesome symptoms or complication as esophagitis, stricture, or Barrett esophagus, and sometimes adenocarcinoma at the end of the spectrum of this disease. So the pathology of gastroesophageal reflux disease, there is impaired esophageal clearance, diminished peristalsis, decreased salivation, impaired tissue resistance for the mucosa, and decreased resting tone of the lower esophageal sphincter, what we call sometimes transient lower esophageal sphincter relaxation that occurs for unknown reason, especially at night, and this transient lower esophageal relaxation does not occur with swallowing, but it occurs and permits for the refluxate to stay for a long time in the lower esophagus and delay the gastric emptying, are the pathophysiology of gastroesophageal reflux disease. There is only weak evidence that lifestyle factors aggravate the gastroesophageal reflux symptoms: obesity, smoking, physical activity, and overeating, and delayed gastric emptying with high fat content in the food. Lower esophageal sphincter is pulled distally by expanding the fundus when we have a large meal, so when the stomach distends, the sphincter is pulled distally in the balloon, and this will lead to shortening of the neck or the high pressure zone, permitting reflux, and this results that the squamous epithelium is exposed to gastric juice. The phenotypic classification of GERD is NERD, non-esophageal reflux disease. When we do endoscopy, the patient has symptoms, but when we do endoscopy, we don't have any aspect of erosive esophagitis and no complication in the mucosa. The erosive esophagitis occurs in 20 to 30% at the end of the spectrum. The squamous epithelium has some sort of metaplasia into columnar lined, what we call the columnar lined mucosa of the lower esophagus, which is Barrett's, and this metaplasia, if it is of the intestinal type, it has the hazard and the probability of around 5 to 10% to turn malignant, forming the adenocarcinoma. This is the clinical presentation. It has been detailed in the lecture of gastroesophageal reflux. Heartburn and acid regurgitation are the typical symptoms. The atypical symptoms that are not esophageal, that are around the spectrum of the GIT tube or the esophagus: chest pain, laryngitis, asthma, sinusitis, chronic cough, aspiration pneumonia, tooth decay. The complication of gastroesophageal reflux is esophagitis, mucosal injury with or without heartburn, and the detail of the esophagitis by endoscopy has been detailed in the lecture of gastroesophageal reflux. Chest pain, respiratory complications, metaplastic and neoplastic complications as Barrett esophagus and adenocarcinoma. Norman Barrett in 1950 described first time the process whereby the esophageal squamous epithelium changes to columnar epithelium, occurs in 7 to 10% of patients with gastroesophageal reflux disease. The factors that predispose to Barrett: early onset GERD for a long time, GERD present for a long time, abnormal lower esophageal sphincter or motility disorder, mild reflux of gastric and duodenal contents. Barrett's metaplasia harbors the problem in Barrett metaplasia that it may pass to a grade of dysplasia, and this occurs in 15 to 25% of the cases of Barrett. 5 to 10% of these dysplasias are high-grade dysplasia, and high-grade dysplasia may the next step is to turn in carcinoma in situ and adenocarcinoma. So the true risk of adenocarcinoma in Barrett esophagus is estimated as 0.5% per patient per year. The spectrum of the disease, you have normal esophagus, you have esophagitis, this is grade 2, Savary-Miller, and this is grade 3, this is stricture, and here you have some sort of adenocarcinoma, so non-erosive disease, Barrett esophagus, esophageal adenocarcinoma is the spectrum of the disease. The diagnosis, most of the time in gastroesophageal reflux, is based on symptoms and heartburn, typical symptoms, heartburn and regurgitation. If they are present alone and you are sure of this, you have done the diagnosis. If you are not sure, you have to investigate either by, probably by endoscopy, and endoscopy will show you that this is gastroesophageal reflux with complications or without complications, or if there is another problem. So the differential diagnosis is achalasia, diffuse esophageal spasm, other esophageal motility disorder, carcinoma in this region, peptic ulcer disease, and coronary artery disease. So we don't need investigation to make the diagnosis of gastroesophageal reflux if the symptoms are typical, heartburn and regurgitation, and the empiric treatment of gastroesophageal reflux gives a good effect and the patient becomes asymptomatic. If we have some added symptoms or alarming symptoms as dysphagia, for example, odynophagia, which is pain on deglutition, and if we have bleeding, whether that's in the form of anemia or overt bleeding, hematemesis or melena, or we have epigastric pain, or we have atypical symptoms as chest symptoms, heart symptoms, and so on, investigation should be done, and the clinical diagnosis should be supported by investigations that we have already spoke about them. Hiatus hernia is one of the other pathologies that could be present in the region of the hiatus. It is herniation of part of the stomach into the chest through the esophageal hiatus. We have two types of hiatus hernia, whether the sliding hiatus hernia, where the stomach and the gastroesophageal junction herniates into the chest, and the other is the paraesophageal hernia. The high pressure zone, the gastroesophageal junction, is present anchored in its region, but part of the stomach herniate near the esophagus or near the gastroesophageal junction through the hiatus, what we call the paraesophageal hernia. When the hernia becomes too big, too large, we have the mixed hernia, which is a mix between sliding and paraesophageal hernia. This is the lower esophagus, this is the stomach, there is no herniation. This is a hiatal hernia, sliding hiatus hernia. Part of the stomach has herniated with the gastroesophageal junction into the chest. So this is the gastroesophageal junction, and this has herniated into the chest with part of the stomach. This is the paraesophageal hernia. We have the gastroesophageal junction below the diaphragm, here in the abdomen, but part of the stomach has herniated nearby the gastroesophageal junction into the chest, which is this is the gastroesophageal junction in its place, and this is the paraesophageal hernia, part of the stomach herniating through the esophagus. This is clear. Here is the gastroesophageal junction. This is the diaphragm. This is part of the stomach herniating, and this is a paraesophageal hernia. One of the importance of the anatomy of the hiatus is its application to surgery and the application to the type of surgery which we will do. So one of the surgeries which are done around the region of the hiatus, and the anatomical knowledge will help in practicing and doing this type of surgery, is the anti-reflux surgery and repair of hiatus surgery. So the aim of an anti-reflux surgery is to restore the intra-abdominal part of the esophagus, to dissect and bring back to the abdomen the herniating part of the esophagus, to approximate the diaphragmatic crura, because when this occurs, most of the time the right crus or the crura around the hiatus become redundant and the opening is wide, so we have to approximate this by some sutures, and if there is a hiatus hernia we have to reduce it, and to maintain all this region in the abdomen we narrow the esophageal hiatus, but also we perform some sort of fundoplication around the lower part of the esophagus to increase the pressure in the high pressure zone and to anchor the stomach and the esophagus in the abdomen. So this can be done transabdominally or transthoracic. Both can be performed through either open or laparoscopic or thoracoscopic, and the gold standard operation is the Nielsen fundoplication, where a fundicrap is done for 30-60 degree around the stomach, around the lower esophagus, following a hiatal repair. So if done laparoscopically, this is done through trocars introduced in the abdomen. This is the disposition of the trocars. This is how the surgeon and the assistant and the helping nurse stands. This is the laparoscopic tower with videos to see what is done inside. So we start by mobilizing the gastroesophageal junction. We cut the lesser, the short gastric vessels that attach the fundus of the stomach to the spleen to permit for the fundus to be free and floppy and to turn around and to be easy to turn around the esophagus, not causing tight compression if it's not floppy and mobilized. And then we dissect around the hiatus to reduce hiatus hernia or to bring back the lower part of the esophagus in the abdomen. So you see here that we have at least 3 to 4 centimeters of esophagus introduced in the stomach. The opening is wide. This is why we are going to approximate it by some sutures, and to maintain the stomach in and the esophagus in the abdomen, we do a fundicrap. We take the fundus of the stomach, we turn it around the lower part of the esophagus, we take sutures, and this is, we say, the Nielsen fundoplication. It's a complete wrap around the esophagus. This is why we call it a 360 degree fundic wrap, which is different from a partial wrap of toupee, which is 270 degree. The importance and the value of this technique is to diminish the pressure in the region of the repair, making less dysphagia to occur. There is an anterior fundoplication, what is called the door technique, which is not very effective and is not usually done for gastroesophageal reflux. It is done with achalasia of the cardia to buttress the site of the Heller myotomy. Achalasia of the cardia. It's failure of relaxation of the lower esophageal sphincter. So this is the lower esophageal sphincter. It does not relax because there is etiologically it does not relax in this region. The true cause is not known, but there is some nervous derangement for this area that prevent gastroesophageal, that prevent the lower esophageal sphincter to relax. The lumen is narrow, the endoscope passes difficultly, and if we do a barium, we have we have a dilatation of the esophagus and the narrowing of the of the lumen of the lower esophagus and the gastroesophageal junction. So, achalasia is a primary esophageal motility disorder characterized by the absence of esophageal peristalsis. There is no peristalsis in the esophagus. The esophagus is not contracting in peristaltically, and there is impaired relaxation of the lower esophageal sphincter. It does not relax in conjunction with swallowing. So normally when we swallow, the lower esophageal sphincter relaxes, peristaltic activity brought the bolus to the lower end of the esophagus, which finds the lower esophageal sphincter relaxed and permits it to pass into the stomach. This does not occur. There is no peristaltic activity to propel the bolus of food down into the esophagus. It comes with gravity and its weight, and when it comes at the lower esophageal sphincter, it is closed and it does not relax, and the colon of food increases the pressure. At this time, some of the food and some of the contents in the esophagus passes into the stomach, making stagnation of food and contents into the esophagus, making it to dilate and giving the sense of dysphagia. So the lower esophageal sphincter is hypertensive. These abnormalities cause a functional obstruction at the gastroesophageal junction. Barium swallow demonstrating the bird beak appearance of the lower esophagus, which is a central smooth stricture at the lower end of the esophagus, different from the malignant stricture, which is usually eccentric. This is a central stricture which is irregular in most of the cases, and stasis of barium in the esophagus. So this is the bird's beak appearance. This is dilatation in the esophagus. This is the gastroesophageal junction with bird's beak narrowing. This is the barium. So if we do manometry, we see that there is no peristaltic activity. Peristaltic contraction of the stomach is usually present in the same time in the different parts of the esophagus, upper third, lower third, and middle third. Contraction is present all the time, and there is no peristaltic activity by high pressure, and there is lower esophageal sphincter of high pressure and does not relax on swallowing. So the treatment of this problem is, the primary treatment is considered by many to be a laparoscopic hilar myotomy, where the muscles at the region of the gastroesophageal junction, they are cut, the sling fibers. This is why we go at the gastroesophageal junction and we cut 1.5 centimeter of the musculature at the gastroesophageal junction, going down on the stomach to cut some of the sling fibers, and this will permit to diminish the pressure in this region, and some of the fibers of the longitudinal and circular muscle fibers of the esophagus are cut, and we have to take care not to do a perforation in the mucosa, and at the end we can do some sort of door technique to prevent reflux and to buttress the mucosa and to protect the mucosa of the stomach. So this is the hilar myotomy. Vagotomies. Around the esophagus, we have seen that there is a right vagus and left vagus. There is an operation that we do. We do it less now because of medical treatment is good for the treatment of peptic ulcer, but vagotomies has been usually done for the treatment of gastric peptic ulcer, and it is a surgical cutting of the vagus nerve to reduce acid secretion in the stomach. The vagus nerve is the nerve that stimulates the parietal cells to secrete acidity. So when we cut them, there is less stimulation and there is decrease in the acidity inside the stomach. So the vagus nerve trunk splits into branches that go to different parts of the stomach. Stimulation from these branches causes the stomach to produce acid. Too much stomach acid leads to ulcers that may eventually lead to create an emergency situation. A vagotomy is performed when acid production in the stomach cannot be reduced by other means, other medical treatment. The purpose of the procedure is to disable the acid producing capacity of the stomach. It is used when ulcers in the stomach and duodenum don't respond to medication, which is usually rare nowadays, and changes in diet. It is an appropriate surgery when there are ulcer complications, and we do more surgeries, more vagotomies today for the complications of the ulcer disease, of the peptic ulcer disease, than to treat the peptic ulcer itself. So 30 years ago, a lot of vagotomies has been done for treatment of peptic ulcer because there was no medications, or the medications which was present at this time was not so effective in diminishing the acidity, but with the but with the introduction of the proton pump inhibitors, as they are good medication, very effective medication in reducing the acidity inside the stomach, the acidity of the stomach. So nowadays, no more surgeries are done for treatment of peptic ulcer. Peptic ulcer is treated by medical treatment most of the time, but sometimes ulcers are reluctant to the medical treatment. Sometimes they do complications in the form of bleeding, perforation, stricture, and so on. And this case, some surgeries for this is done, and surgeries are done. And when they are done, vagotomy may be part of the surgery. So the frequency this is what I explained 20 years ago, but nowadays no more done, because the primary cause of ulcer is thought to be an infection by a bacterium called Helicobacter pylori. Drugs have become increasingly effective in treating the Helicobacter pylori and the increase in the acidity of the stomach. A vagotomy procedure is often performed in conjunction with another gastrointestinal surgery. Why? Because at the vagus has two actions. It increases the acidity or stimulates the parietal cells to secrete acid, but also it permits the mobility of the pylorus and permits the pyloric sphincter to relax, to make the stomach evacuate its contents. So if we cut the vagus trunk itself, we have spasm of the pyloric sphincter, and the stomach does not evacuate its contents, and this is why when we do a truncal vagotomy, a main vagotomy, we have to, this should be done with a drainage procedure, which could be an antrectomy or gastrectomy or gastrojejunostomy or a pyloroplasty. There are three basic types of vagotomy: truncal or total abdominal vagotomy. The main vagal trunk are divided, and surgery is accompanied by a drainage procedures such as pyloroplasty. We cut the pyloric sphincter, and we approximate it we cut longitudinally and we approximate horizontally, and this makes the sphincter less effective and permit for the evacuation of the stomach. Or we do a gastrointestinal drainage by a gastro-jejunal anastomosis, or there may be a selective gastric vagotomy that cut the branches that goes from the vagal trunk to the parietal cells and leaves the nerve of Laturgé, which has a motor part for the pyloric sphincter, permitting it to relax, and this is a highly selective vagotomy. The selective vagotomy, the main vagal trunk are dissected to the point where the branch leading to the biliary tree is divided. Then they are cut, and this procedure is rarely indicated, and it was done in the the early areas time, because after truncal vagotomy there were some cases of continuous or long-standing diarrhea. So these are the types of the vagotomies. This is the truncal vagotomy. We cut the main vagal trunk, and so the celiac branches and the hepatic branches were cut, and this sometimes the patients may suffer from diarrhea, ballottement, and distension, and this is why it has been thought that if we cut after these branches, the celiac and the hepatic branches goes out from the vagus trunk, so this will diminish this, but this is no more done, and the new highly selective parietal cells will leave the vagus nerve completely, but when they give branches to the stomach, each of them is cut, and this prevents the stimulation of the parietal cells to produce acid, but the nerves of Laturgé that goes to the pylorus are maintained, and this permits relaxation of the lower of the pyloric sphincter. So this is the anterior division, or the anterior vagus and the posterior vagus. This is the pyloroplasty. So if we cut the trunk here, we do a pyloroplasty. We cut longitudinally the sphincter and we suture horizontally. We do anastomosis between the stomach and the jejunum, permitting the food to pass through the anastomosis directly into the stomach, and they don't stagnate due to spasm in the pyloric region. So this is the truncal vagotomy. You cut here the main trunk. This is the selective vagotomy. You leave the celiac branch and the hepatic branch, and you cut the rest of the vagus nerve. Here we leave the vagus nerve with nerve of letter J going to the pylorus, but we cut the branches that goes to the parietal cells. This is the vagotomies. I think the last one of the pathologies around is the malignancy that could be encountered at the gastroesophageal junction. This is whether Barrett esophagus that turned into malignant, and this is an adenocarcinoma of the lower esophagus that may invade the cardia and the fundus, or it may be a tumor from the cardia that goes upward and infiltrates the gastroesophageal junction. So this is the gastroesophageal malignancy with obstruction and on barium. So third classification: type 1 adenocarcinoma of the distal esophagus, and type 2 true carcinoma of the cardia arising immediately at the esophagogastric junction, type 3 subcardial gastric carcinoma that infiltrate the gastroesophageal junction and distal esophagus from below. This is the last slide of this topic. And for the gastroesophageal malignancy around this area, many types of surgery can be done, but one of them is resection, total gastrectomy with gastroesophageal with esophago-jejunal anastomosis, or when the lesion is in the cardia or the lower esophagus, we can do what we call stomach pull-up. Part of the stomach is cut at near the lesser curvature, maintaining the fundus, and the stomach can be pulled in the chest after cutting part of the esophagus and doing a esophagogastric anastomosis. This is the Elrwini procedure, and this passes through the hiatus. Thank you. This was the topic for the anatomy of the hiatus. We have seen the surgical anatomy of the hiatus, the crura of the diaphragm, right and left crura of the diaphragm, the aspects of the competence around the gastroesophageal junction, the lower esophageal sphincter, the different types of diseases which occurs around this region, and the gastroesophageal reflux disease, the hiatus hernia, the achalasia of the cardia, the vagotomies that we do sometimes, and the malignancies around this area. Thank you.